Work nicely. First of all, on behalf of my very best friend and colleague and of myself, let me express a lot of thanks to the organizing committee and personally Nicole for giving us this great opportunity to be with you, with this great audience, and to share our knowledge, our narrative, and our perspectives in some very interesting topics. So, as you already understood, this topic will be dedicated to very specific multidisciplinary subject that is orthodontically induced root resorption and the teeth vitality. So both these subjects are basically kind of side effects of almost every orthodontic treatment. And what's interesting to know, and that's why we are here today, to show you the correlation between these side effects or these subjects. And meaning that we can, or we will see today, the influence from one side, the influence of orthodontic treatment on the vitality of the teeth, and from other side, how the vitality of the teeth, or vice versa, how the unvital or non-vital teeth influence the orthodontically induced apical root resorption. So both these things are very interesting, compromising, and still controversial in the literature. And that's why we are here to share some perspectives on these two subjects. So let's start. Hopefully, again, the slides are going well. So let's talk first about the orthodontically induced apical root resorption and what is that and what is the etiology of these side effects. So as you know, just trying to get rid of this.
Put it here.
Here,
yeah.
Just a second. I'm trying to reduce a little bit of screen in order to share the maximum. Okay, let's do it here.
This one, I just wanted to help you.
Okay,
good.
Okay,
it's okay.
So sorry again, some technical problem. So first of all, let's talk about the etiology and or several subjects, because when we're talking about orthodontically induced apical root resorption, basically talking about something caused by orthodontics. But sometimes we have almost the same side effects or quite a similar side effects with the periapical area that was not caused by orthodontic movement. And we have quite several reports in the literature. You can see even in early 90s, we have several reports dealing with the orthodontically or basically apical root resorption that doesn't necessarily connect it to the orthodontics, but definitely connected with something else. For example, we know that several patients suffering from kind of parafunctions or having some harmful habits like nail biting or open bite caused by tongue thrust may cause almost the same side effects as orthodontically induced root resorption. That's why we can, for example, we can name them or we can call them like stress-induced or mechanically induced apical root resorption. So what are the main risk factors? And as we're talking about the etiology and risk factors, we know that there are several risk factors that may couple each other, but among them, the most important are the biological factors, for example, the genetic factors, the individual susceptibility for to have these side effects, or for example, some medical background. For example, we know that several diseases, especially those who based on autoimmune processes, have much higher susceptibility to have these kind of resorption. The second very important risk factor is the more specific morphology of the teeth. For example, those teeth, especially the incisors, will with the elongated or abnormal roots, or those have kind of bayonet-shaped roots, they also have much higher risk to have orthodontically induced root resorption. And of course, some specific orthodontic modality or movements, for example, like intrusion, that definitely have much more side effects that, for example, extrusional forces, or in the cases with the abuse or overuse of class 2 elastics, have an increased chance to have more root resorption. And you can see in these this slide that especially with the intrusive orthodontic forces and coupled basically with the specific morphology of bayonet-shaped roots, you can see these red areas or red dots. It basically expresses all these areas with the increased chances for root resorption, and they are concentrated, or all the stresses are concentrated, especially in these specific areas. So what we should know about root resorption, how should we be, let's say, concerned about these side effects? Let's say that in most orthodontic cases, hopefully for us, of course, there are always some degree of root resorption and some degree of either histological or rentgenological root resorption may be experienced without any clinical significance, again, hopefully for us, meaning no periodontal involvement or no endodontic involvement and no parafunctional activity. So, but there are still several cases, and we know about these cases. Unfortunately, they happen some, but in these specific cases, when the orthodontically induced resorption is very progressive and almost involving almost 50 or more than 50% of the root, we have unfortunately several additional side effects. So several questions may be raised in these specific cases. And one of the first and probably most important questions that usually we are raising, or these questions are raised among the colleagues. First of all, does these kind of teeth that with the huge involvement of root resorption, what's going on with their vitality? Is the vitality of the teeth is influenced by this process? This is the first question. So if yes, if the vitality is somehow involved in these cases, so maybe there is necessary to perform root canal treatment. So this is one of the questions that we have to raise. So, and another question, of course, is there a need of a root canal treatment? Maybe we need them in order to stop or somehow to regress the progressive process of root resorption. So as you see, we raised several questions. Hopefully after this lecture, we can answer these questions. And we still have a lot of controversy in our existing literature. So my friend will continue with the answers.
Hi, good evening, everybody. I'm trying to remove something. Okay, we have two interesting questions. Whether endo-treated teeth prevent or increase orthodontically induced root resorption. And the second question, does root canal treatment will stop ongoing orthodontical root resorption? And if we will check the literature and we will check different clinical cases, we can find real controversy. And I will try to give an answer to this controversy. Okay, first of all, please see this case on the right side. You see that the vital tooth had much more prominent resorption of roots, and the tooth with root canal treatment almost doesn't have signs of resorption. But on the left side, you see the tooth with root canal treatment and huge apical resorption, and you see gutta-percha outside because of this. Why we can have these two types of phenomenon in our clinical practice? It's very interesting. And one of the most interesting things in our field in dentistry is the story of neurogenic inflammation. With the time, we understood that the function of nerve system is not just, to send the signal to central nervous system, but also to influence local processes. You will have some irritation. Of course, it can be microorganism irritation, or it may be mechanical irritation of the nerve fiber. For example, by orthodontic movement, we have a pressure on nerve fibers in apical part of the root. We have a reaction from the neurogenic tissue. We have nerve sprouting, and we have secrets of neuropeptides. And neuropeptides like CGRP or substance P can influence all the inflammation process, and to start inflammation process, the name neurogenic inflammation. And a couple of interesting researches, like the research of Kaku, we can see that during orthodontic movement, we have a peaks of secrets of some neuropeptides, and in the end, we can see a very noble marker of inflammation, like interleukin 1 beta and tumor necrotizing factor alpha and increasing of wrangle. And we understand that if we have a tooth with vital pulp, because of this vital pulp, we have here higher inflammation. And one of the ideas of author of this specific article was to show us that if we have tooth with vital pulp and tooth without vital pulp, we have no nerve tissue, we have no neurogenic inflammation. And in this specific case, ideally, we will have much lesser root resorption. It's interesting article, it's super interesting data, but please don't start to endo for every tooth that go through the orthodontic treatment. It's not the goal. It's not the goal. By the way, if you do endodontic treatment is ideal situation and vital pulp, what's the predictability of this treatment? If we will check it by regular X-ray, 95%. If you will check it by CBCT, 87%. It's not a way to do endo for all the teeth that go for orthodontic treatment. But we understand that when we finish orthodontic treatment, in most of cases, orthodontically induced resorption will stop. But in several very rare cases, we see that this resorption can continue. And in these specific cases that we see continuation of this resorption process, we can think to do root canal treatment. But again, a very small quantity of all the orthodontic cases. It's no prophylactic endodontics for the orthodontic patient. It's one part of the story. Second part of the story, how in this specific case, we see so prominent and huge resorption. By the way, it's not exactly orthodontically induced resorption. Why? Because I see here some radiolucent area. Maybe here we have two mechanisms. Maybe we have orthodontically induced resorption and apically inflammatory root resorption, because we have radiolucent area, because we have here also apical periodontitis. Maybe before that we started in this specific case orthodontic movement, we had apical periodontitis. It's super interesting question to check the already endodontically treated teeth before we are starting the orthodontic treatment. For example, here, no apical lesion, but please take into account that many years in endodontics, we understand that we don't see about 30% of apical periodontitis on regular endodontic two-dimensional X-rays. Just on CBCT scan, we really can evaluate if we have some hypodense area or no. And sometimes, most of cases today, not in sometimes, in most of cases today, in the world of ortho, they don't use CBCT scan. Is I'm right? Okay. For example, please see this very interesting case. before the starting orthodontics, like 6 months later, on this low molar, suddenly you see a new lesion on mesial root and a little more big lesion on distal one. Why? I have two explanations. On mesial root, for example, maybe no lesion exists before, or maybe it was a lesion that was invisible on regular X-ray, but now we see it. By the way, on the primary X-ray, the area, radiolucent area on distal root was very small. And we know these cases. We have good quality endodontic treatment. We have good quality corneal seal, and you see some small radiolucent area. And for example, you have no older X-ray. Maybe it's healing process. Maybe it's scar tissue. We don't know. And in most of cases, we will prefer follow-up and don't retreat this case. But I think it's important to understand today that CBCT must be used much more in orthodontic practice to understand if we really have some signs of apical periodontitis. But again, if this examination will give us full guarantee for early pretreatment detection, I tell you the truth, I think no. I want to share with you amazing articles that were published in 2024 by a very famous group from Brazil, group of Professor Siqueira. Okay, in this article, what they did, they took an apical 5 millimeter of the endodontically treated tooth with apical lesion and without apical lesion. And what they found was amazing. First of all, in all apical 5 millimeter of teeth with or without apical periodontitis that find microorganisms. Of course, they show us again our endodontic topics, the importance of quality of obturation and importance of quality of corneal seal. But again, all the teeth row with microorganisms. And we suddenly understand again and again that all this situation very, very gentle. We have some balance. We must understand that full sterilization in contemporary endodontics not real. What we are doing, what we endodontists doing, we do maximally efficient disinfection, but microorganisms, some microorganisms inside. And sometimes we have between them and between our body and immune system balance. And in this balance, we have no disease. But in orthodontic treatment, orthodontically induced root resorption can disrupt this balance by resorption of intermediate cement. And in this case, during apical percolation, glycoprotein-rich periapical fluid will go in contact with microorganisms and will disrupt the balance. And we have now apically inflammatory root resorption. Of course, it's our, with Dr. Shapinko, elegant speculation about cases like this. But I think that this is the way. And we must understand that sometimes we will do CBCT, like this case, before the orthodontic treatment, and you see no lesion on mesial root, and maybe you see some small hypodense area on distal, and you start orthodontic treatment, and on a regular X-ray, you see the few lesion on mesial root. We must understand from medical legal point of view that we can't give full guarantee to the patient that by CBCT scan, we can, to give him guarantee that we will have no problem on apical lesion. It just emphasizes the need for follow-ups. Just during follow-ups, 6 months after, or sometimes maybe 3 months after the beginning of orthodontic treatment, we can have decision about endodontic intervention. please.
So, what are the conclusions of today's seminar, and how can I summarize everything here already heard from us? So, several questions were raised this evening, and I will try to answer all these questions that were posed today. So, the first question is very important. First of all, does teeth vitality is influenced by orthodontically induced root resorption, even if we have some progressive root resorption? So our answer, is no. In most of the cases, the vitality of the teeth is not influenced, basically is not adversely influenced by orthodontically induced root resorption, even in its progressive stages. So the second answer will probably derives from the first one. So is there a need for root canal treatment in orthodontically induced root resorption cases? In most of the cases, no. We don't need to make root canal treatment in the cases that are experienced to orthodontically induced resorption, even in the progressive cases. But again, we will discuss it a little bit later. So the third question that we raised, are the teeth with root canal treatment have higher chances to orthodontically induced root resorption during the orthodontic treatment? So our answer basically is no. Or to be more detailed, more precise, in most of the cases, the teeth that already went through a root canal treatment have basically even lower chances for orthodontically induced root resorption. And my friend Michael already explained all these neural systems that basically plays a huge role of causing or promoting the root resorption. The fourth question, in some cases, the increased incidence of root resorption, orthodontically induced root resorption, may be explained by endodontic origin, is basically not from ortho. It's probably from those micro films or microspheres that basically remain usually in almost every endodontic treatment, endodontically treated teeth. So the next question is there any need for root canal treatment to stop the progression of orthodontically induced root resorption? And again, our answer is in most of the cases, no. As we know already, as orthodontic treatment ceases, as far as endodontic treatment continues, it might be continuing with the resorption. But if the orthodontic treatment ceases or stops, usually we have a cease of orthodontically induced root resorption process. So in these specific cases, we need just to stop the orthodontic movement. And we know that in the most of the cases, usually the resorptional process stops with us. But, and this is probably the last or maybe the most important taking home message, in several highly progressive cases, that even if the orthodontic movement stops, and you can see the progression, unfortunately, despite of the cease of orthodontic movement, you can see the progression of the root resorption. In these specific cases, we may propose to make the root canal treatment as probably I can call it a panic treatment or last chance remedy. And I think this will be probably our last summary and conclusion. So first of all, let me again express my thanks to the organizing committee and those who joined us today's evening for being with us, and we're glad to share with you this narrative. Of course, it was very short, but it's just the beginning, I can promise you. And I would like maybe to have some opportunity to extend my invitation and invite all of you to my course that will be held in Tallinn in 1 month, in 15 of March. And this course will be dedicated to the aligner therapy. We will talk this course will dedicate it not just for the experienced orthodontics, but mainly probably for younger doctors, for non-experienced practitioners who just started their treatment with the aligners and who already experienced some frustrations or mistakes with the aligners. We will talk because again, we will talk about the basics or the basic principles of biomechanics on the aligners. We will talk about the differences between the aligner therapy or the biomechanics of the aligner therapy and the bracket system. We will talk about the communications, or basically about the errors and the mistakes of communication between the doctors and technicians. So I can promise that it will be very interesting. So please join us. And again, have a nice evening. And the last word from my friend, please.
Before we will start answer your question, just couple of words about my next two-day course in Tallinn in May 2025. I have 2 different days. One day we will be dedicated to all about the cracks, from the crack to syndrome of vital tooth to VRF on non-vital tooth. And again, I will explain why and where and how we will diagnose it. And I will show very interesting new treatment approaches on this so noble and so growing problem in our patients. The second day, totally different one, a day about tooth with open apex. And here I will go through the vital pulp therapy to apexogenesis and maturogenesis, through the classical apexogenesis and apical plaque technique, with many interesting surprises in this field, because mainly this field influenced by marketing of very expensive things, and sometimes we can have amazing result and by old and very good techniques. And of course, part of this day will be all the story of the dispute between revascularization, revitalization, regeneration. I invite you, and I'm sure you will enjoy it. And now we open for your questions.